Bismillahirrahmanirrahim. So the first type of vasculitis we are going to discuss is giant cell arteritis. Giant cell arteritis is actually granulomatous inflammation of large to medium-sized arteries present in the head and neck. The most common artery that is involved is temporal artery, followed by ophthalmic and rarely vertebral arteries as well. Giant cell arteritis is most common type of vasculitis in the West, as well as the most common type of vasculitis affecting the old age. The disease comes to clinical notice often after the age of 70 years. The pathogenesis of giant cell arteritis is rather unknown. The presumption about the pathogenesis is that there is an unknown antigen present inside the blood vessels, which result in a T cell mediated response against the blood vessel. So the T cell mediated immune response results in arterial granulomatous inflammation causing vasculitis known as giant cell arteritis. The name is driven from the formation of granuloma and presence of giant cell in the center of the granuloma. Grossly, the artery appears to be cord-like with nodular thickening of tunica intima. As you can see, there is nodular thickening of the temporal artery. This thickening results in narrowing of the lumen, and occasionally there is a thrombus present inside the lumen, which further narrows down the lumen. The histological picture reveals granulomatous inflammation of the tunica media, which results in, first of all, necrosis of the tunica media. As you can see, this is tunica media of the temporal artery, and there is necrosis and degeneration of tunica media. The second effect of granulomatous inflammation is fragmentation of elastic lamina. Elastic lamina is present between the tunica intima and tunica media, and the granulomatous inflammation results in the degeneration of elastic lamina in some spots, resulting in its fragmentation. The main inflammatory cells present are CD4 T cells, macrophages, and the giant cell is present in almost 75% cases of giant cell arteritis. This here is a giant cell. So what exactly is a giant cell? Giant cells are actually large cells which are formed by the fusion of many other cells such as macrophages. The cells are typically large, have multiple nuclei, and since it is formed from the multiple cells fusion, these cells share their cytoplasm to form extensive cytoplasmic area. These giant cells are typically present in the center of the granuloma. In rare cases, eosinophils and neutrophils along with B lymphocytes are also present in the biopsy segment. There is hyperplasia of the tunica intima, and often there is a thrombus in the lumen, as you can see here. So tunica intima hyperplasia and thrombosis in the lumen cause narrowing of the artery, resulting in the ischemia. In rare cases, both the granulomas and the giant cells are absent. In such case, the diagnosis is established on the presence of panarteritis and excessive leukocytes infiltrate. The disease occurs as either a continuous lesion or it may occur in the form of skip lesions. Skip lesions mean the alternate segments of non-pathologic and pathological areas. Giant cell arteritis typically presents in the late age, mostly after 50 years, but most commonly it occurs after the 70 years. And the patient presents with the vague symptoms of fever, fatigue, and weight loss. The typical symptoms depend upon the artery which is involved. In case of temporal arteritis, there is pain along the course of the artery, there is headache, and often scalp tenderness. In rare cases, jaw claudication is also present. The artery is visible on the temporal region, and it is cord-like and nodular, and it is often painful on palpation. The symptoms associated with the ophthalmic arteritis are more severe, and in 50% of the cases, the patient presents with abrupt loss of vision. Whereas in other 50%, the patient at first develops diplopia, which means doubled vision, which is followed by blurred vision and ultimately blindness. Ophthalmic arteritis constitutes a medical emergency. The blood picture reveals raised erythrocyte sedimentation rate or ESR, and often normocytic normochromic anemia is also present. The diagnosis is established on clinical features, raised erythrocyte sedimentation rate, and a good response to steroids. In doubtful cases, biopsy of the artery is done, which indicates granulomatous inflammation, presence of giant cells, inflammatory cells, and moreover there is elastic lamina fragmentation. The treatment is typically with the steroids such as prednisolone and immunosuppressant drugs. The disease has a good response to steroid therapy. So this brings us to the end of discussion about giant cell arteritis. If you have any questions, do let us know in the comment section. Thank you.